I do have the honor to introduce the next speaker, a very dear professor, and he's from Ain Shams University, professor of cardiovascular medicine in Ain Shams Medical School, Professor Ahmed Shawky, and he's going to give us some case scenarios and when good and isn't good enough. The LDL new targets, a very interesting title.
Thank you. Good afternoon, everybody. It's lovely to be here. We're going to change it a little bit. Let's stop the one-way discussion and let's make it a two-way. And I would like to encourage you to help us in voting in certain aspects of these case presentations, please. Of course, these are my disclosures pertaining to this presentation. Let's take a patient coming for a follow-up. If you look at this patient, she's 53, she's young. She's diabetic for 12 years. She's well controlled. You can see the hemoglobin A1C is 6.5, normal ECG, normal echo. The LDL is 145. The triglycerides are 167. First question that comes into mind, what is the problem? We've been asking ourselves, what causes mortality in patients with diabetes? Who do you think? It is cardiovascular. If you look at the first important top global causes of death in those with diabetes, in those with COPD, it is still ischemic heart disease and stroke. And of course, 2/3 of patients with diabetes have any death rate exception بسبب atherosclerosis, and this is important. Not only controlling blood sugar is important for the control of death, it also avoids a lot of complications that we see on the slide above. So I remind you of our patient, a 53-year-old female, just type 2 diabetic. She's been for 12 years. And this is our first question. What do you think her cardiovascular risk is? Is she low, moderate, high, or very high? Do we got the O? You can scan the QR code and vote, please. I would like to understand how we are thinking in whole. This is really important. Just 15 seconds, that's it. We're not going to waste a lot of time. Anybody having voting? Anybody who does not want to vote can just put a show of hand. I would like to thank the technical team for helping us with this. Thank you so much. So Professor Gamila, what do you think? She is low, moderate, high, very high, Professor Mick? What would you say? Just a quick answer. She's 53, type 2 diabetes for 12 years. No complications, no other problems, very well controlled.
Maybe she's high, very high, very high.
Very high,
Yes, very
high.
risk.
Who would say she's moderate risk? Who would say she's low risk? Who would say she's high risk? Who does not know how to raise their hands? I think a lot of you. You're not raising your hands, okay. How do you calculate this? This is the score chart. This is how in Europe, and a part of the Egyptian Society of Cardiology is part of the European Society of Cardiology, we help with their guidelines. We don't use that. No, we don't. Why? Because we only use it if the patient is not diabetic, if the patient does not have established cardiovascular disease, if the patient is not a familial hypercholesterolemia or CKD. If the patient is diabetic, we have certain criteria to assess the risk of this patient or not. If the patient has established cardiovascular disease with diabetes, he or she is very high risk. If the patient has target organ damage, he or she is at very high risk. If the patient is diabetic with 3 or more major risk factors, he or she is very high risk. Our patient who has a duration of diabetes more than 10 years is a high-risk patient. Only some diabetics, younger patients with a lower duration of diabetes have a low risk. So it's important to understand most diabetics are going to be in the high or very high risk category. And this comes to the next question. How about the treatment targets? I know there are a lot. She's already at hemoglobin A1C, her already blood pressure is well controlled. How about her LDL? One of the most important parameters that reduces primary prevention. Let's try a quick vote again. If anybody has a problem with voting, please, how much? 55, that's very ambitious. And I'm sure Professor Mek will not disagree because, you know, back in the UK, they have different guidelines. They don't advocate the European guidelines. Even the ADA advocated the European guidelines this year for the targets, but not in the UK. They're a little bit different, cost-oriented, which is very good. Who would say 116? Who would say 100? Who would say 70? I'm like in an auction here. 55? Professor Mek, where would you go? Where would you go? 55, okay. Very ambitious. This is important. Of course, I'm not going to discuss what this says, but one of the important parameters of treating a diabetic patient is risk factor control, including the cardiovascular risk. This is an important pillar, controlling the blood pressure, controlling the blood sugar, controlling the blood lipids. And actually, if you look at how each factor improves outcomes, blood lipid and blood pressure control in diabetics has a higher percentage of well-being than blood sugar control. Not to say blood sugar control is not important, it's extremely important. Second of all, LDL lowering is not a J-curve. If you go too low, there is no increased mortality. There is no reverse relationship like blood pressure, like blood sugar. It's actually linear. The lower, the better. And we have data from Odyssey outcomes up to 15. We have data from Fourier up to 10. It is safe. Not only that, the higher the LDL, the higher the benefit of the lipid lowering in reducing outcomes, in reducing complications. And the big problem is we're not reaching that. This is an example of one of the biggest countries with a vast health insurance, Germany. Germany is one of the biggest well-established health insurance countries in the world. If you look at the control of hypertension, it's quite good. Diabetes is not that bad. Hypercholesterolemia, it's terrible, nearly 20%. This is really important. And of course, the guidelines have become more and more, difficult to reach. If you have a very high risk, you go to 55. If you have a high risk, you go to 70, like our patient. It's 70. We don't need to go to 55 unless we have a little bit of a problem. And if we look at the data about HMG-CoA reductase inhibitors, statins, this is really important because they have shown an incredible decrease in mortality in patients with diabetes. And this is why the guidelines state dyslipidemia in high or very high risk patients in diabetics, we should reduce LDL by more than 50%, and this is only achieved by high intensity statins. Of course, if we're not reaching that goal within a few weeks, we should up-titrate to ezetimibe. This is not data from us cardiovascular data. This is also data coming from the ADA just published a few months ago. And you can see, again, for the very first time, they advocate the European targets, not the American targets of going below 70 in those with high risk and even 55 in those with very high risk. And of course, the dilemma of triglyceride lowering, which is important if the patient is at high or very high risk, actually the benefit comes from icosapent ethyl, not just fibrates. We took a twist. Our patient, she was doing very well. All of a sudden, she had a chest pain. And she got to the ER. Her troponin was elevated. I tried to change the patient, but I said, let's make a patient go into everything. So what is the next step? This is my question to me, because I'm the one who's in cardiology, me and Dr. Yasser and all other cardiologists. Well, we just updated the guidelines in the acute coronary syndromes. For the very first time, both STEMI and non-STEMI were included in the guidelines, which was published a couple of months ago. And of course, the earlier invasive procedure, that is the patient to go into angiography and recanalization of the occluded vessels, this is really important. But the question comes, we gave her antiplatelets, we gave her heparin. Do we give statins, or do we wait until we get a lipid profile? This is important. What do you think? Who goes for A? Wait. Who goes for B? Immediate. Okay. Do you have data to support this? That's important. That's very good. Thank you for your interaction. Well, actually, if you look at data for risks of myocardial infarction, the most important with the highest hazard ratio is the elevation of the cholesterol levels. The data from years and years ago that one of the most important things that were introduced in ACS to reduce mortality were statins and early invasive procedures. Those taking statins had a better outcome than those who are not taking statins. And anybody with a documented atherosclerosis, whether acute, whether chronic, is considered very high, and thus we have to lower their LDL very quickly. But the question goes, why are you guys opting for giving statins immediate? LDL lowering takes a little bit of time. Do you think it's for the LDL, or for their pleiotropic effects, or maybe A and B both work? Dr. Jamila, would you like to comment on this?
Yes, there were ups and downs, pleiotropic effects, but I think we can have both, because you can, there are maybe 7 effects of these statins, being decrease the fibrosis, decrease the arrhythmias, so maybe I think both of them.
Okay, that's a very good point. So, excellent, excellent, this is very good. I am the person who likes evidence. I do not like theory only. If it was for theory, beta blockers are contraindicated in heart failure. Beta blockers are the most important mortality reduction medications in heart failure. If you look at this data coming for the very early initiation of statin therapy, high intensity statins in those with an acute coronary syndrome, if you give the patient the first day, the day of arrival, it's better than the second, the third, it's a significant reduction of outcomes. And the pleiotropic effect, agree to it or not to agree to it, it is there. They are not just LDL lowering, they do reduce a lot of other parameters. And if you look at the guidelines, all guidelines, years and years ago, till now, statins in immediate on admission for an acute coronary syndrome, because they do advocate good outcomes for our patients, and it's an important parameter to improve outcomes for those with an acute coronary syndrome. Anybody listening to the last ASC guidelines and the ACS, and they even advocated in certain patients for the very first time, this is the very first time for dyslipidemia, that we can start with combination therapy, not a very high level of evidence, not a very high class of recommendation, combination therapy from the start in those with a high risk. And of course, there is this data coming, again, this is just a consensus, this is not guideline, that if the patient has an extreme high risk, like recurrent myocardial infarction, polyvascular disease, we might start with triple therapy, including the PCSK9 monoclonal antibodies. Okay, so we gave the 80 milligrams of atorvastatin. A question, when do we repeat the LDL? We're trying to go with the parameters of follow-up. When? Was it 1 to 2 weeks, 2 to 4 weeks, 4 to 6 weeks, or 6 to 8 weeks? Okay, that's good. We can stay for 5 seconds more on this question. I think this is really important, because actually there is a lot of discussion here, and there were a lot of opinions. I'll show you what the opinions go. Okay. In MCQs, this is called a good distractor, that a lot of people are answering different questions. So there is a good question. Okay, thank you. So most of us said 4 to 6 weeks. Actually, this is what the guidelines just said in 2019. This was not the same data that was in Europe and the United States, in Britain, and Canada. But this changed just a couple of months ago, maybe just under a year ago, also in the consensus provided by the ACCHA. Again, they agreed to the follow-up of 4 to 6 weeks. Why? Because when we wait, we have inertia. When we have inertia, we don't up-titrate, we don't add, patients die. This is important. A quick question, what is the LDL target in our patient? When she was at high risk, it was 70. What do you think it's gonna be here? This can go very quickly. Thank you so much. Thank you so much, this is perfect. I think we can skip the question. There was, till very recently, a debate across the Atlantic. Europe, it was 55. United States, it was 70, but the ADA in 2023 agreed with Europe and said those at established cardiovascular disease should go to 55, which is really important for their outcomes. But we did not reach our target. We're still at 108 with atorvastatin and ezetimibe. What would you do? This is an important question. Sure? Final answer? I think because Professor Mick just told us that in the previous lecture, I think we could agree and we could go into that. Somebody's saying polyunsaturated fatty acids. That's really interesting. Okay. So PCSK9, what do? They remove LDL by recycling LDL receptors. Simple as that. And they are a class 1 indication on top of statins and ezetimibe to reduce outcomes in patients with ACS. If you look at the algorithm, you start with statins, you add ezetimibe 4 to 6 weeks. I'm talking 4 to 6 weeks, not 4 to 6 months. Then a PCSK monoclonal antibody. And I here say what the guidelines say and the ACC consensus says. Inclisiran comes at a later level if there is no PCSK9 monoclonal antibodies or there is a problem with giving PCSK monoclonal antibodies. What is the data of PCSK9 inhibitors in ACS? It's Odyssey. ACC 2018, it was the breakthrough. For the very first time, there was a reduction in mortality in acute coronary syndromes on top of statin therapy and ezetimibe by adding alirocumab, and this was really important. Not only did it reduce LDL by more than 50%, it reached up to 62%, but it reduced all-cause mortality, and it was the first time for a medication to reduce all-cause mortality for years and years. And this was there. But what if our patient has another ACS within a couple of years? Do you think we should go lower than 55? Just a question of theory. Would you go lower? Yes or no? Yes? Where? Where do we go? 40? 35? 60? 20? Perfect. Let's go to the next question. Well, actually, this was answered, 4 years ago in the guidelines. Thank you. In the guidelines, I'm trying to stick to time, very sorry, that we can go up to 40, which is 1 millimole of LDL, if the patient has a recurrent event within 2 years. So sorry for taking a lot of your time. Thank you for your interaction. But we should take home that diabetes is a very important risk factor. Not only is it blood sugar control, we're controlling the patient. We're treating a patient, not just levels, blood pressure, and of course, lipid levels. The LDL is probably the most important target till now, not the triglycerides, not just the total cholesterol. Getting to the recommended guideline goals is the way to reduce mortality, reduce events, and recurrent events. You have statins, up to high-intensity statins. You have ezetimibe. You have monoclonal antibodies like alirocumab, evolocumab. Use them, because this is the way we're going to treat our patients and get them better. Thank you so much.
Thank you.